I'm Dr. Michael DiTolla, and you are watching episode 108 of Chairside Live. Megan Strong is still out on assignment. Actually, Megan has completed that assignment, and here is a picture of that assignment. That is one incredibly gorgeous baby. Megan Strong is now healing from that assignment and should be back soon. Today's episode's got an interesting case of the week and an interview with one of my good friends, Dr. David Hornbrook. David's one of the only dentists that I know who knew he wanted to be deeply involved in aesthetic dentistry from the time that he was in dental school, and I never really knew why, but we find out why today. We also get his thoughts on some of the new modern high-strength all-ceramic restorations and some of the other things that he's been doing in his office, including his ongoing over-the-shoulder courses that he continues to do. In this week's case of the week, I'm walking through the all-ceramic department, and I find out for the first time that we're actually doing our diagnostic wax-ups differently today than we have been doing them for the last 15 years. We're finally able to harness the strength of CAD/CAM to fabricate these diagnostic wax-ups, and at the same time, it allows us to store that file and help to give you and the patient the aesthetic result that you've seen with the diagnostic wax-up. So let's go ahead and take a look at the case of the week. I was walking through the all-ceramic department the other day and saw something that I thought was worth pointing out. It's a 2-unit diagnostic wax-up that a dentist has had done for a patient where he's going to be preparing 2 crowns. And one of the interesting things is that we now do these via CAD/CAM. So a diagnostic wax-up used to be done here in the lab. It took a lot of time, and it was slowly done by a couple of different technicians who kind of specialized in it, and they would hand wax everything up and carve it back, and it would get stuck actually to the model itself. It would adhere to that, and then if you liked how it looked and the patient liked how it looked, you'd ask us to try to reproduce that in the final restorations, which we could do with a varying amount of success based on the case. These are now CAD/CAM diagnostic wax-ups. So these are milled out of a white wax, and then we can lute them onto the model. And the interesting thing about this is when we do that, we now save the design of the CAD/CAM milled diagnostic wax-up. And so this file, this design file, gets saved in our servers. And so if you show the diagnostic wax-up to the patient and the patient likes it, you go in and prepare the teeth and then say, please use that same file to mill my e.max restorations, for example, or this doctor actually prescribed BruxZir for this patient. And so this same design file can be used to mill the final restorations that was used to mill the diagnostic wax-up. We used to have to try to guess at this a little bit when we would do it, but now, thanks to CAD/CAM, we can do it exactly the same and literally with the same file mill it, except being at a wax, which I could crush with my fingers here, it can be with something stronger, such as e.max or such as BruxZir. And so if you look at the preparations, this is what is required for the doctor to do to be able to achieve these final aesthetics. And so one of the things that I've kind of played around with, we've looked for a more translucent wax. This isn't completely translucent, but looking for something where when you're prepping these 2 teeth and you know you want to get enough reduction to be able to do this, I think it'd be nice to be able to have a set of these and something maybe a little bit stronger than wax, of course, like PMMA, where you could try them over the preps, and as soon as they sat down all the way, you would know that you were done prepping. In fact, if it was something, you could almost use it for your temporary if it was something a little bit stronger, but you could probably do chairside temporaries and have them look really nice as well. But you know as soon as this goes down into place that you've got enough preparation so that the laboratory is going to be able to duplicate this. And so usually what we'll do is we'll do a suck down, a thermoform stent over these teeth to send to the doctor where you can try it in over it. And that's not a bad way to do it. The doctor used it on this case. He actually didn't send it back, or I'd show it to you. But it's not probably as exact as being able to try 2 units on like that and having it go down into place. The doctor also gets a thermoformed version of this, of the diagnostic wax up in place in case he wants to use this to fabricate the temps. Or the way that I'm more common with this, I'm more used to is this putty matrix, which you can make chairside, but we always send these out. And this is a putty matrix where we have putty and a wash material of the diagnostic wax up. So if you wanted to do chairside temps, you would just fill this with a bisacryl, put it in over the temps, and be done with it after you trim it. But let's look at what the doctor actually did. Well, before we look at the model, here's the impression. So it was a full arch impression, well, a full arch tray. The impression stopped a little short of that. We've got a little bit of the molars there. That's fine. That's gonna work. It'd be nice to have a little more, but we can work with that. We can see the margins. Things look good. I actually really like his bite registration. We just did a course here on bite registrations, and all we want to see on a bite registration is the incisal third of the 2 prep teeth. So we could have even gone with a little bit less material. We're just going to trim it with a scalpel. And then on the other side, we have the incisal edges of the opposing teeth, and that's all we want there as well. So a bite registration is not supposed to be a full arch horseshoe all the way around the arch when it's just 2 teeth in the front. All we want is the incisal third of the preps and the incisal third of the opposing teeth. We don't want any adjacent teeth, soft tissue contact. So that's perfect. That tiny little thing is actually exactly what we're looking for and is a perfect bite registration. So back to his preparations. As we look at the preparations, let's compare it to what our technician did for the diagnostic wax-up. And so the strict instructions that technicians have is to remove, and it's the same person who designs the diagnostic wax-up shells. So they're trying to remove the least amount of tooth structure to get an aesthetic result for the patient. And so as we compare them, we can see that a little more was removed on the diagnostic wax-up prep guide than we see here. And as we spin it over to the facial and try to look, a little more reduction was done in certain areas on the facial. And the lingual sometimes can be hard to tell, but it looks like we still, the incisal edge is a little bit thicker. And when this got scanned, it looks like there's now not enough room to be able to accomplish, you know, what was done here with the diagnostic wax-up. And that's one of the reasons when I show this to the patient and they say, oh, I like how it's going to look, I say, well, you know, here it seems to appear to be okay, but sometimes in the mouth, there's things that happen, different little optical illusions or the way the restorations sit, where I want you to consider something. And I have this conversation if we're just doing 1 central incisor or 2 like this, and I bring up the possibility of no prep veneers on these 2 teeth, on the lateral incisors. And I said, we may not need to do this. We might try this in. You'll be perfectly happy with how they look and we'll be all finished. But I want you to consider one thing, and that is that teeth oftentimes look the best when the front 4 teeth match, or depending on how big your smile is or what your aesthetic needs are, you know, we'll go back 8 or 10 teeth and go all the way back. But to do a single unit tooth is extremely difficult. And to do the 2 centrals is a little bit easier, but still sometimes there'll be a different shade than these other teeth. The eye teeth are always darker, so if we can get 7 through 10 to be the same color, then we're really the same shade, then we're really doing well. So oftentimes I'll tell the patient it may not be necessary, but I want you to know that, you know, if making these 2, we put 2 no prep veneers, so no shots, no drilling on these teeth, then all of a sudden your front 4 are going to match, and they aren't supposed to match these cuspids, and so that's really a great way to do it. Some people will jump at it then. Some people will like these teeth but think that they're facially more prominent than these once we put these into place, and they'll say, well, maybe we should do those no prep veneers. I just like to bring it up to say, look, there's an ideal way to do these kinds of cases. Not everybody's into it. You know, the most ideal way would be to go all the way back to the second bis here, but maybe these teeth look fantastic. But if not, if we're going to have, you know, a big shade change between the centrals and the laterals, I just always bring it up so they know what's happening. But when we look at what the doctor's done, where we don't quite have enough reduction to do this, but we're close. You know, we can still make these, but they're going to end up being probably a little bulkier on the facial than we were here, and so that screams out a little bit more for a couple of no prep veneers. We could also put a reduction coping on here and do a little more reduction for the doctor on the incisal edge and the facial and have him replicate that in the mouth, and actually just waiting on a return phone call back from the doctor to see what the doctor wants to do. But that's really what got me thinking about this idea of what if you had 2 units like this, and instead of just a suck down that kind of fits around here is a little hard to see, what if you had 2 units like this where you could keep trying them onto the preps in the patient's mouth, and once they went all the way down and you had a passive seat, you would know that you were good to go. And actually, you'll see I can't even get these really on here at all. And part of that's because of this, there's kind of a path of insertion issue. You can see that the prep on number 9 is definitely tilted towards the mesial like this, when in reality it should be kind of tilted, a little more like this, just slightly to the distal. And even tooth number 8, when I look at it, it's got an inclination going this way, which is okay, but it's not drawing with this one. And so this can probably help guide you. In fact, if this was clear and completely translucent, it would probably be more helpful to be able to see exactly where there was contact between the two. And again, they did send out a suck down that goes over these preps for the doctor to try in the mouth, but I don't know. I mean, it's good, it helps, but it's kind of difficult sometimes because it's got to fit over all these other teeth. And so this case got me thinking about doing the DWAX and being able to do this. So I don't doubt we're going to end up with a good aesthetic result here. We might need to prepare a little more on this tooth. If the doctor says, hey, we're turning pink, I can't take any more off, then that might be a time to tell the patient, I talked to the lab and told them we couldn't reduce anymore, so this might be a little bit bulky. I can have him make those other 2 no prep veneers right now, all 4 at the same time, or we can try these 2 and see what you think. But kind of got to let the patient know. And there are times where the only way to really get a great aesthetic result would be with elective devitalization. You may have to do endo on this tooth to get enough facial reduction to get it back into the arch where it needs to be aesthetically. So the point being that I'm going to continue to work on looking for a clear material to help us get that right. But that really is the key, because if we can recreate this in the patient's mouth, then we know that we're going to be able to have permanent restorations that are milled from the exact same file as the diagnostic wax up. If the patient's not into the idea of endodontics and we're bumping into some deep dentin here and it's starting to turn pink, that would be the time where we could tell the lab, well, we prepped all we could on these 2 teeth and couldn't go any farther. Let's talk about doing 2 no prep veneers here. So anytime it's an anterior case where we're not doing the 4 anterior teeth or all 8 from second bite to second bite, I will bring up the possibility of needing some no prep veneers to complement whatever else we're doing in order to get an ideal smile. I don't force them on the patient. I just say, let's keep this in the back of our mind, because if we do this and do all 4 or do all 8, we know we're going to get the best aesthetic result that we can. And I know that's why you're doing it in the first place, is for aesthetic. So it's nice to be able to know that with a diagnostic wax up that you show the patient, if they accept it and you're able to prep that much away, we can now duplicate those exact size, contours, everything in the final restorations with the millable material like e.max or BruxZir. Part of our Chairside Live Expert Series, we've got with us today a good friend of mine, Dr. David Hornbrook in San Diego, California. David, how are you doing this morning?
I'm doing great, Mike. I'm doing great. Thanks for inviting me.
And it's great to have you here. And for everybody, I think, who's had an opportunity to see you speak before, you're definitely best known for your commitment to aesthetics and wanting to do anything you can to help improve the smile of your patients. I want to go back a little bit, back to when you were in dental school. And most of us had no inkling really of aesthetic dentistry in dental school. Somehow, in some crazy coincidence, I got to do the first 6 veneers in the history of the University of the Pacific. They probably could have chose a better student to do it, but I got to do the first 6 ever because this patient wouldn't stop bugging the head of the Crown and Bridge department to let me do it. And that, first of all, I learned, wow, people will not take no for an answer when they want a better smile. Nobody was petitioning, for root planing or endo or things like that. But she really wanted these veneers done. And even then, it really didn't click with me. To me, it was just something that I got to do that no one else did. I want to know, back in dental school, how'd you get interested in aesthetics, and how did it all kind of happen? Was it in dental school or was it afterwards?
No, it was absolutely in dental school. I think like a lot of us, the dentists listening, you included, we went to dental school to help patients, help people, work with our hands, be creative, be artistic, make lots of money. Well, let's forget about that last one, but certainly the first 4. I mean, instead of medicine, I think we went into dentistry because we are good with our hands. And what I found out early on in dental school, and you can certainly relate to this, is dental school is not about being creative. they put a tooth in the middle of the room and you had to match it. If you decided that you wanted to be creative, you failed. If I decided I think 2 cuspicera bellies would look better than 1, I failed. And so I was very frustrated early on, realizing that it wasn't about being artistic, it wasn't about being creative. I had a very unique opportunity between my freshman and second year of dental school. I actually got hired by BruxZir. BruxZir did a program where they brought dental students in. They gave us all their products. And then that summer, we would go to dental offices basically as salesmen to try to sell product. Excuse me. And at that time, Durafil had just come out, and they had all these cool little colors, all these things that all our instructors in dental school had never seen before. So all summer long, I was playing with all this very cool stuff. I came back in the fall of my second year, and when we had to learn to do a direct composite on a typodont, at the gingiva, I was doing all these cool things on posteriors. And all of a sudden, everyone kind of woke up. Even the instructors were coming over and saying, let me see how you do that again. Let me see how you do that again. It was the first time that I saw excitement in dentistry, because now we could be artistic. And so that's kind of where it started, where I thought, wow, maybe there is an opportunity to be aesthetic. And then Bruce Chrisman, who was an instructor of mine, he had a huge influence because he showed us that teeth can look like teeth. And that's the first time I had seen that as well. I thought crowns were supposed to look ugly and they weren't supposed to match existing teeth so you could find them later or something like that. But he certainly influenced me in that regards. And my first case in dental school, I went and saw Bob Nixon, who was, again, another huge influence on me, as a third-year student on the Queen Mary, actually. He spoke with Dan Matterdomini, and they showed beautiful dentistry, and they had this great relationship with each other, and they shared this beautiful dentistry that I thought, what a cool part of dentistry to be able to do that. And so I went back with a patient that had tetracycline in dental school. And I went to my instructor and said, I'd like to do 6 veneers on this patient. Of course, he said, no, and they don't work. Porcelain veneers don't work. And so my first aesthetic case, because the patient, I guess, didn't petition enough, or I didn't, is I cut 6 PFMs on these virgin teeth. And at UCLA at the time, we couldn't put porcelain butt joint margins, so we had to put 0.2 millimeter metal collars. I had to bury them subgingival 2 millimeters. And that was my first aesthetic case. Of course, it looked like crap, if I look back at it now. When I got out, then I had the freedom to say, okay, I'm going to practice the way I want to and be artistic, be creative, explore materials, explore educational venues.
It's really amazing that it all started because of that BruxZir opportunity, because as you were telling me what that opportunity was, I'm sitting here thinking, is that even legal? Can you just take students and say, here, we want you to play with these, now go sell it? Did you get a commission when you would sell it in the dental office?
Oh, absolutely. Absolutely.
Okay.
I mean, we were basically hired as salesmen. The funny thing is, at least at UCLA, we had no exposure to any dentistry our first year. So we went out, and I would go to a dental office, and the dentist would say, so where can I use this? And I'd say, oh, this is unbelievable. Class 4s, Class 3s, Class 2s, Class 1s, Class 5s. I had no idea what those were. I had no idea what those even meant. But I sold some stuff, which was good, and it was a good experience. And we got to keep all that grip stock at the end of the summer, and that's what I took back to school.
I'm glad you knew it was a Class 1 where he could use it. You didn't say, oh, first class or something like that. And show your absolute
Well, you probably could have done it in first. That might have sold more, maybe.
But
the dentist would have been as confused as I would have been.
Exactly. It's interesting because you mentioned that, and you think now, take a dental student today, and what if between their first year and second year they did something like that, either with aesthetic products or maybe implants, and then learned everything about this implant line and went into offices and talked about it? It does seem like a great opportunity as a dental student to really get submerged in this, because when I go to dental schools, like I go to Loma Linda every year and do a program, a lot of them haven't heard of our lab, and most dentists have because we advertised constantly, but they haven't really even heard about, full zirconia crowns. So you're so insulated when you're in dental school. You're really kind of not a part of dentistry yet. So that's a neat program. And speaking of full contour zirconia, I'm going to be interested to hear what you think about it, because as an aesthetic master, when full contour zirconia started life as a decidedly unaesthetic restoration, but it was stronger than anything else, and we just designed it basically to be used on posterior teeth. We thought if you say, hey, let's do cast gold, and the patient says no way, it would be a restoration for that. I'm wondering, have you had the opportunity to try any of these? Are you too in love with e.max to give full contour zirconia a try?
No, I absolutely have done some full contour zirconia. And what's kind of interesting is when it first came out, I don't know if you remember this, but I called you and said, hey, Mike, can you send me a couple? And not from a case. I just want to see what this stuff looked like, right? And of course, the early ones were bright, big, white crowns, you know. And actually, I was surprised the anatomy was good and the custom staining on the surface was good. But it was a white tooth. Now, when I look at that, I think, okay, what are our options for the average dentist? Not me, not you, but the average dentist who likes to cement everything still with zinc phosphate and Duralon, right? And they want it easy. They don't have to isolate. They want something familiarity. Their option was gold and PFM. All right. So, you know, PFM typically they under-reduce, as you know. Mm-hmm. So they under-reduce, which means it's opaque. You can see the metal or certainly the roughness of the opaque at the margin. Or they do a metal occlusal. So if we compare aesthetics and also the ability, the flexibility and universality of full zirconium versus a PFM. I mean, full zirconium is head and shoulders above the PFM, in my opinion. Not only in aesthetics and flexibility, as you know, if a dentist decides to reduce 0.7 on a molar, that PFM, you know, in a couple of years, there's going to be a little metal spot where the porcelain broke dead center on the occlusal. We can do that with full contour zirconia. And you also look at strength, that marginal ridge or even that central fossa where that porcelain fails on that metal. I mean, we're looking at a material that's 10 to 15 times stronger being full zirconia than that PFM. So strength and aesthetics in the posterior, comparing to a PFM or gold aesthetic-wise, I think it's a huge opportunity for dentistry. Okay. Do I use it on occasion? You know, I have some nocturnal patients, nocturnal BruxZirs that will not wear an anti-bruxing device. And studies have shown that, you know, near the hinge axis, they can exert forces nocturnally up to 500 megapascals. So even with e.max, and I do like e.max, that'd be my preferred restoration. I've had e.max break on second molars close to the hinge axis. So that's when I use full contour zirconia, or when I have very tight occlusal clearance or interocclusal clearance. You know, we've done full zirconia at 0.5, 0.6 on the occlusal surface, where the only option would have been gold or PFM with a metal occlusal. So I think it fills a huge void. I have no problem. I wouldn't use it if I had all the parameters ideal. If I had a clearance, I could isolate. e.max or lithium disilicate or lithium silicate would still be my choice, but I think there's a place in dentistry. The other thing, the other place I think that it's a huge place is elimination of metal. Right. You know, as you know, most, I think, with the PFMs that are cemented by dentists in the U.S. are fabricated overseas. And if I look at a magazine, not Glidewell, of course, a magazine I see, I can get a PFM, which includes metal, for $79. There's no way I'm getting precious or semi-precious. I mean, I'm getting some non-precious or some tin or some bumper metal or something, right? So for years, I was telling my audiences when I gave my presentation, and I think we're going to see a huge problem with metal toxicity, marginal inflammation in the future because of all these PFMs with this crummy metal that's being cemented. And zirconia, I can now go and I can see a zirconium oxide full contour for $79 or $99 or $100. And I think more dentists would go that avenue, which I think will eliminate this potential metal toxicity problem that I always thought was going to exist in the future. So yeah, I think there's a huge place.
Gordon Christensen has said for years that that 50% of women will develop an allergic reaction to base metals within 7 years of having it placed. And so there's that, but you'll probably be happy to know then that if you just look at single unit crowns, like for last month, only 9% of the crowns that we did, 9% were PFMs. It's that low. So the single unit PFM is almost becoming extinct. And if you look at the full contour zirconia, it was up to 69% of the crowns that we did. Just absolutely amazing. And if you look at the split anterior posterior, it's there's a couple numbers that stand out to me that are odd. So 69% of our posterior crowns are full contour zirconia, and about 14% are e.max, and that's fine. e.max, if you reduce enough and bond it into place, it'll do fantastic on a molar. That's not an issue, but you're right. A lot of our dentists like to cement and not bond, so I'm always curious about that number. But even stranger than that, if you look at our anterior crowns, 44% are e.max and 31% are now solid zirconia. And we haven't even launched our aesthetic zirconia crown yet. It's going to be about half as strong as it currently is now. So it'll still be about 100 megapascals maybe over e.max. But it looks fantastic. It's really translucent and it looks pretty darn good. But that's without launching that. Already 31% of our anterior crowns are BruxZir, and what the whole industry, I think, failed to realize was just how into strength dentists are. They want something that's not going to break. And so it deals with under preparation really well, and it's the only tooth-colored material that can handle a feather edge margin. Because that's the other thing we see a lot of is feather edge margins. Maybe not around the whole prep, but somewhere on the prep. And it's really kind of a disservice to try to force e.max to try to handle a feather edge margin or make it a really kind of bulky crown at the same time. Another trend we've noticed here is that e.max veneers have pretty much almost taken over for Empress. Empress has shrunk to the point where it's now about 2% of our veneers. I'd be interested, what's your kind of mix when it comes to veneers between Empress and e.max these days?
Well, Empress certainly has fallen off and e.max has taken off. I still use Empress, and what's interesting is not this summer, but last summer, I polled 10 what I would consider master ceramists, people that worked through the Hornbrook group that I've worked for years, and Matt Roberts type of people, Rob Matta, Lance Hancock, Jeff Austin from Utah Valley, and they're, in my opinion, masters at Empress, masters at e.max. And I sent them an email and I said, "You're sitting in my chair. We're getting ready to cement your 10 veneers. They're sitting on my bracket table. What do you want them to be?" All 10 of them said Empress.
Really?
Which is kind of interesting. And, that was a year ago, and I think since then, I think they've mastered a little bit of how to get a bright white smile and not be too gray. That's what we struggled with. So I still use Empress, and the way I teach and what I do in my own practice is if I have a patient that wants a very white smile, if we go to the Vita, let's say B0 or the chromoscope shade guy in 020, 030, if they want a white smile and they have any red or ruddiness in their complexion, strawberry blonde, Irish, Northern European, and they want a bright smile, it'll always be Empress in my office.
So like you, a patient that looks a little bit like you.
Yeah, absolutely. I would not use e.max in my mouth. In fact, when I did my case, we tried them both in. Outside the mouth, on the models, on the prep die, they looked exactly the same. In the mouth, the e.max looked gray.
Wow.
And I'm sure you've heard that from Glidewell, because most of the laboratories will say, "Oh yeah, I've seen that," where we had to send it back. And you look on the model, it looks beautiful. Lithium disilicate tends to gray out. Now, to brighten it up, what the labs are doing is they're choosing an ingot or a block that is actually whiter than they want the final result. Then they down stain it. The results are great, but now we have all this external stain.
Right.
I'm not a fan of external stain. I'd rather have color come through the tooth than to hide that by putting some stain or down staining. So I would say right now I'm probably at probably 50-50. A year ago I would have said 75 Empress, 25 e.max. So I'm doing more e.max, but I'm still an Empress user. I've probably got 100 full mouth rehabs in my practice the last 15 years that are Empress. They're all not failing. I've got 3 in a bridge in the anterior, cantilever bridges of Empress. They're not failing. But like every other dentist, if I can find something that looks as good, fits as good, and is twice as strong, I mean, why not?
Yeah, that's a good point. And even on Jim Glidewell, we had some press veneers in his mouth, and within about 7 or 8 months, he had chipped 3 or 4 of them. We took those off and replaced them with e.max, and he hasn't chipped any of them. In fact, he thought he had chipped one day, and he came in, and I started looking at his teeth, and he hadn't chipped one of his lower veneers. He had chipped one of his upper veneers. He had chipped one of his lower anterior teeth. And that's the kind of material I want, where if I don't adjust the occlusion correctly and protrusive, I want a material that'll break the natural tooth as opposed to having it break. I think I recall in one of the journals that I saw did you actually publish an e.max no prep case?
Yes. I've done a lot of e.max no prep.
Tell me about that, because a lot of aesthetic gurus rally against no prep veneers like they should be made illegal, but it seems there's a time and a place for it, and I guess you agree with that. Absolutely.
I think there's absolutely a place, and you look at people like our age, where the baby boomer age they had ortho as teenagers, so all orthodontists 25 years ago extracted the premolar,
sure.
And then they tried to close the spaces, so everything was brought back. So we lose buccal quarter, we have a deflective profile. I'm not saying us, but as a general population, in the people in 45 to 55. All of a sudden, they're losing muscle and collagen support in their lips. They don't show their teeth. They don't have lip support, and they have a shallow buccal quarter. You look at those, and this is all additive, where I need up to 1 millimeter sometimes of additive to that tooth. So in situations like that, where the teeth are relatively ideal alignment, which most of these patients are because they had ortho, right, even if they don't wear retainers. Most of them, the teeth aren't tetracycline or dark. They're normal shaded teeth, so I'm not hiding something with the thickness of a restoration. And I'm bringing everything out. I think that's where prepless or minimal prep, and I'll say minimal prep is 0.3 millimeters or less. We're still doing wax ups. We're still doing mock-ups. We still take these in the mouth with non-prep. And then I'm going to say minimal prep. I take a 0.3 millimeter depth cutting burr. I go ahead and do all my depth cuts, pop off that mock-up. Lots of times there's no scratches anywhere on the tooth. Why do I need to prep? Now, I would prefer, as you think like a ceramicist as well as I do, I would prefer to put a very, very light margin, just so the lab knows where to finish to. But I've had patients that have come in and they're holding a DenMat ad saying, "Look, no grinding, no handpiece, no drills, no shots." And I understand if those patients don't want that, we can deliver a great restoration. And I think the advantage of e.max over feldspathic, which a lot of people are doing, is I think our marginal integrity of 0.2, 0.1 is much better. And you look at the people that are doing, whether it be refractory or foil, they're peeling that foil away, they're blasting out the refractory. All of a sudden, they don't have any margins left.
Right.
Because they can't. So I think there's absolutely a place.
Yeah, and my favorite place to do it is if you're taking off 4 ugly PFMs on 7 through 10, and you're going to replace it with e.max crowns. e.max no prep veneers on the canines and the bicuspids looks fantastic. What an easy way to finish out that smile if the patient's interested. And about the no margin thing, it occurred to me one day that a lot of the dentists who were complaining, at lectures coming up and saying, no preps aren't any good. There's a speed bump because there's no prepped margin. It got me realizing that we have enough dentists, and I see tons of cases that come through here, where they prep a feather edge margin, say on a posterior, like a lower first molar, and they don't ask for a metal margin. So by definition, we have to have 0.3 of a millimeter of metal, another 1/10 for opaque, and then 0.5 millimeter of ceramic there to have a disappearing margin because they don't want a metal collar. And when that crown gets cemented in the patient's mouth, there's now a speed bump there, the same type they object to in the anterior, except in the anterior, I know that if a patient only brushes 6 teeth, it's going to be these. And to keep that other speed bump on the first molar clean, they're going to have to floss. And we know that's not going to happen for at least half the population, men, and even some women. So I think it's, as long as the patient realizes that, they need to maybe they need to make sure they brush their front 6 teeth is all they need to do. And so I don't have a problem with that little speed bump that's there. I've seen CEJs, natural ones, that look like a speed bump there.
I was going to say, CEJ is a speed bump. And, the other thing is, that you call it a speed bump with that little edge from the porcelain. Again, we're talking about 0.1 to 0.2 millimeters lots of times, and that can even be finished down. That's all positive contours. You think about it, a ponic, is it's all convex versus concave contours. And that in itself is cleansability, and there's a difference between that speed bump and an overhang. An overhang being where there's concave contours where plaque will accumulate and trap, and I totally agree, because we don't see this. I tend to go back and finish my margins just to polish that down. when I do these no prep veneers, but there's a colleague, a very famous one that lectures on non-prep, and he doesn't touch them at all. And I looked at some of his cases with an Explorer, and the first thing I said to him was, how come you're not finishing these things down? He said, well, I've been looking at it for the last 5 years. I don't see any difference. And so I think the average dentist probably is better to have that little positive contour than to go and finish them and then not polish them.
Right, and that's my big thing is even if you can get a fine tip, fine grit diamond down there and adjust that, you know, it's tough to get polishers down there and know that you're really polishing that well. In fact, if you don't own an electric handpiece, I would say you can't polish it at all. I mean, that's what I've found just playing with, you know, you've got to have electric handpieces if you hope to polish these materials back anywhere near to what we can do in the laboratory. Hey, David, thank you for spending a little time with us this morning. I look forward to bumping into you again somewhere soon. And almost above anybody else, thank you for your commitment to quality dentistry and being an aesthetic guru for the rest of us.
Well, thank you, Mike. I want to thank you for putting this on. I know you're taking time away from your family and your friends, and here it is a Friday morning, and you're educating other dentists, which I think is so important. You know, I feel like I'm a little underdressed. I mean, you look like a Secret Service agent with an earpiece and a black suit, and I'm in my Tommy Bahama, you know, and headphones that I stole from my son's Xbox 360 machine. But anyway, I had a good time as always, and I hope that we're too close not to see each other more often.
On behalf of myself, the CSL crew, and everybody here at the lab, I want to thank you for your time and your continued commitment to quality dentistry. That is one incredibly gorgeous bite registration.